as Dr. Ali was speaking, the microphone is not working really nicely. Nobody could benefit more. Just, sorry, can you hear me? Yes. Houston, everything fine. Okay. Now, robotics is now in our real life. We were dreaming about robotics 10 years before. Now we can use the robots in our daily practice. How realistic is to use a robot for a prostatectomy? We have learned this during maybe last 10 years. Now I can just tell you one. You have seen during the doctor's presentation a list of the institutions. I can just tell you one. Only the urology is using the robot effectively. If it's no urology, it's no robot. Nobody could reach with robot more than 1,000 cases. In urology, I can put you on the table 10,000 cases. It means urologists are using the robot, and they are mainly responsible for the performance of the robot. But they have learned during the last 10 years. Next slide, please. I want to just show you our technique for robotic prostatectomy. All of the people here, the surgeons, they know well how to operate open radical prostatectomy. If you know it, it's easy to understand for you because it's almost similar. Next slide. Before the transperitoneal technique and descending technique was mostly chosen. Slide. We could then reach the bladder neck and vesical terminals. Next slide. But in our technique, it's a little bit different. Slide. It's already published in the literature in the many books. You can go in the PubMed and write Heilbronn technique. You will write maybe 30 papers, maybe more. We are using the retroperitoneal approach. If you are a urologist, your home is retroperitoneal. Because all the urologic organs are in the retroperitoneal area. Because of this, you have to choose the retroperitoneal access. You can go directly to the prostate. You will not touch any bowel and your intraperitoneal organs. And you don't need to retract any organs, castrate, normal bowel retraction. And if it's something bad happening, this can happen with everybody, and then you are working in a closed area. Next slide. If it's an intraperitoneal infection or retroperitoneal infection, this will stay in different spaces, and the time will be less because you will go directly to your organs. And CO2 will not touch the peritoneal area. Next slide. Why we are using Da Vinci robot? First, to make it clear, nowadays we have no other robot on the market. Do you know why? Very simple. We heard about Zeus. Zeus was very nice. We started with operating with Zeus. Intuitive come, take Zeus. The others, they developed something, Intuitive come, take all the patents. Now all the robotic patents are in the hands of Intuitive surgeons. This is why we are using robotics. This is not a fair situation, but I hope this will end in near future. But when you are using Da Vinci robot, you can use optimal exposure, 10, 15 times more. You cannot see like this with your eyes during open surgery. You can prepare with 0.5 millimeter instruments. You cannot do it in a small pelvis with your hands. You can suture. You can never suture in open surgery or laparoscopic surgery such kind of precision. And the instruments are really offering the nice dexterity, and during the suturing with magnification you can perform high quality reconstruction. This is not because of you, this is because of robot. But don't forget, robot is not doing anything alone. You can put the robot here, the patient there, nothing will happen. You will need good surgeons, you will need human beings, you will need human knowledge. Without human knowledge or talent, robot is nothing. Next slide. Very nice freedom, and you can handle with your hands nicely. No tethering. If you are getting older, more than 50, 55, 65, you will need a robot. That's why almost more than 70% of robotic surgeons are over 60 years old. Not surprised. More? But it's working with robotics very nicely. Asking me, I had a scoliosis after 10 years laparoscopic experience, I developed a scoliosis. They told me, oh, you cannot stand more than 3 hours, and then you cannot operate. Okay, what I have to do? To go and operate with robots. Okay, I can just sit here, I can control with my foot and with my hands. If I'm getting angry, I want to go take a coffee, I can leave the console, go take a coffee, and then come back. Next slide. And as you can see here, the vision is really excellent. You cannot see with your own eyes something like this. Next slide. And who can learn robotic surgery? You are an excellent laparoscopic surgeon, but maybe you are not good for robotic surgery. Do you know why? When you are working with laparoscopic instruments, they are straight instruments. You are working like this. But robotics, you need these movements with your hand. You forget these movements with the time when you are performing always laparoscopy. But if you are operating manually, open, and you skip the robot, as you can see, this is the learning curve of an open surgeon, and this is learning curve of laparoscopy. As you can see, you can learn easily as open surgeon, robotic surgery. Next slide. In Heilbronn, we had everything actually. We had experience in extraperitoneal space, experience in laparoscopy, experience in